first speaker, Dr. Macatangay, I have the following disclosures. So we have a lot of learning information today. We will start the session with Dr. Bernard Macatangay.
Hello, good afternoon, everyone. I'd like to thank the organizers and members of PMA New England for the opportunity to talk to you this afternoon. Next slide. So just a little bit of a background. I know that you've gone through coronaviruses and the epidemiology during the past webinar, so I'll just go through this quickly. Coronaviruses are important. They've been they were discovered in the 60s as etiologic agents of the common cold. They're widely circulated in the human population, but since 2000, there have been strains of this coronavirus that had animal reservoirs and occasionally spilled over in humans. The most recent one, of course, is SARS coronavirus 2. The R naught, or the basic reproductive number, could probably be different depending on what your source is, but from this paper from Emerging Infectious Diseases, when they looked at case reports and key epidemiologic parameters in the Wuhan experience, they computed the R naught to be at 5.7, meaning that for each case of COVID-19, there are 5 to 6 people who are susceptible individuals that could be infected with the infection. Next slide. This is from the Johns Hopkins dashboard, and this really changes regularly. So this is just as of this morning, and I bet if you look at it now, the number of total confirmed cases and the global deaths would have changed. The only thing I wanted to point out is that what is key for this number to continue to increase is really the fact that the virus is shed several days, 5 to 6 days before the onset of symptoms. And this pre-symptomatic or asymptomatic shedding of the virus plays a critical role or significant role in the transmission. And so unless we take that into consideration, it's going to be tough to control this infection. Next slide, please. You've gone over some typical and atypical symptoms. I just wanted to emphasize, fever, dry cough seen in about 50 to 60% of individuals, but there are also atypical symptoms. And in some of these atypical symptoms, this was the paper that was published in JAMA that looked at alterations in smell and taste. This was seen in around about 60% of individuals having these symptoms either prior to the onset of the other symptoms, at the same time, or even after. Or some of our experience here in Pittsburgh, we've had patients who experience this a couple of weeks even after they resolve from the symptoms of fever and cough. There are also some dermatologic changes, as you see here, the COVID toads and some maculopapular or urticarial rashes. Next slide. So I wanted to spend more time on diagnostics. I think this is important. So the Infectious Disease Society of America and others, the recommended diagnostic test would be nucleic acid amplification test, or the PCR. And if you look at this figure, which is from Nature Medicine, it was published earlier last month, you can see that the amount of virus or the level of the viral load that is there is very high very early on in the disease, as you can see there. And it goes down. So typically by day 21 or 3 weeks right after, it will be approaching the limit of detection. But if you look at, so that's basically the mean or the median, as you can see, the thick line that's there. But there's a lot of variability, so that other people may have even higher levels of viral load between day 14 and 21. And there's this one point there where you could see at day 28, there's a spike there of a viral load. So even if typically we see that this is decreasing by day 21, there is a possibility that there are some individuals that after day 21, you would still see some levels because of the variability. One important point to remember is that the PCR is not a test of viral replication, which means that even if we detect the shedding of the virus, 3 or 4 weeks after the onset of symptoms, it does not necessarily correlate with transmissibility. Right? It does not point into replication, but just that they are able to detect the RNA in that. Next. So what are the guidelines? As I mentioned, it is using the PCR testing, and what the IDSA recommend is to get a nasopharyngeal or mid-turbinate specimen rather than oropharyngeal or saliva. I know there was a paper that just got published from the Journal of Clinical Microbiology that showed an agreement, a 96% positive and 99% negative agreement between nasopharyngeal and saliva. But based on other data, I think it's like an N of 150 for this paper. But based on other data, there's still a bit of a difference between the sensitivity and specificity of getting it from the nasopharyngeal compared to oropharyngeal and saliva. So that is still what the recommended testing is. Now, do you repeat testing if there's high suspicion? For symptomatic individuals that you have a high degree of suspicion that that person has COVID-19, then there's a recommendation to repeat it. However, if you have an individual where the suspicion is low, then the recommendation is not to retest these individuals. Now, how about asymptomatic testing? Just an important point to bring up is that there's very little evidence for this. So these, if you look at the IDSA guidelines, they say these are conditional recommendations, which means there's not enough data to actually show that this is something that's important, but they're being recommended at this point. So it's a conditional recommendation based on very low evidence. When do you test asymptomatically? For people who are exposed, so someone who was exposed to a person that was a confirmed COVID case, someone working in a hospital or a place of work where there is an outbreak of COVID-19, long-term health facilities. Immunosuppressed individuals who are being hospitalized, or people who are going to the hospital and undergoing an immunosuppressive procedure, meaning that chemotherapy. And then something that we've been doing here at Pittsburgh, and I think there are other centers looking at this as well, patients who are being scheduled for elective surgery or aerosol generating procedures, they test that 2 days or 1 day prior to the procedure to see if the patient is infected. Next slide. The other thing that's been coming up is the serology testing. And there are loads of these antibody testing kits that are available. But if you actually look at the ones that are approved by the FDA for emergency use, it's probably, I think the last time I checked, there were about 13 tests with sensitivities for IgG in the 90s to 100%. And similar negative predictive values for these particular tests. So don't just pick one test, make sure that you look at the FDA website to see which are approved and that you have an idea what the values of the sensitivity, specificity are. The multiple tests available would be testing, or there are various antigen targets, the S protein, the nucleocapsid, or the receptor binding domain, which is also in the S protein. These antibodies, less than 40% of individuals will have these antibodies within 1 week from onset of symptoms. But by 14 days or day 15, you could see that 100% of them, and this is total antibody, IgM, IgG, or IgA, about 100% of these individuals will have positive antibodies. And the seroconversion typically happens between 5 to 14 days. Now, for some individuals who are coming in with symptoms and they would have a negative PCR, this paper was published at the Clinical Infectious Diseases by Guo et al. Showed that when they combined a PCR negative with IgM ELISA in these individuals, you actually have an increase in positive detection from 51 to 98.6%. There may be some use of an IgM ELISA in those individuals that are symptomatic with a PCR that is negative. Next slide. So when do we actually use serologic testing? So important. Identification of individuals that have been previously infected. So we are now looking at a lot of epidemiologic studies, prevalence rates, and all that. The serology would be very helpful in trying to do these epidemiologic studies. Second, we are hearing about this convalescent plasma. So it's possible that we can use serology testing to identify potential donors for convalescent plasma. Third, immune responses. So there are a lot of vaccine candidates right now that are being evaluated. So those who are participating in these clinical trials for candidate vaccines, then you can look at titers and antibodies to see whether it was able to generate enough antibodies. The vaccines were able to generate enough antibodies. And then finally, possibly, as I mentioned in the previous slide, to aid in the diagnosis in those cases for patients who are symptomatic but PCR are negative. However, when do we not use serology? Again, the recommendation is to use nucleic acid amplification, so we do not use serologic testing for diagnosis of acute and recent cases. And number two, very important, determining protective immunity. Remember that there may be antibodies that are formed, but it's not sure whether these antibodies are neutralizing antibodies, right? So that does not necessarily correlate that if you have all these antibodies that are being formed, that you are immune from this, because you still need to test whether these antibodies are neutralizing of the virus. Next slide.